very important conditions. Because of their wide clinical presentation, they come with differential diagnosis of number of neurological disorders. This is the outline of this presentation. Let's start with this case scenario of 12 years old girl presenting with sudden onset of one-sided weakness along with focal fits. This was followed by signs of raised ICP in the form of headache, vomiting, and drowsiness. And there was history of previous upper respiratory tract infections 2 weeks back. This is the common case scenario that routinely encountered by the pediatricians. So what would be the possibilities? These are the differential diagnoses. You can appreciate this is the whole neurology. Not only the neurology but also the systemic causes of raised ICP could be the possibilities. So with such a broad clinical presentation, what would be the approach? This needs a scaled approach based upon the sound clinical knowledge and careful interpretation of the signs and symptoms. There is a big group of disorders in children that collectively called as inflammatory brain diseases. This is a very huge group, contains number of disorders, and demyelinating disorder is one of them. Before we start, we review our knowledge of anatomy about myelination. Myelin sheath is a protective fatty material that wraps, protects, and insulates the nerve fibers of the central as well as the peripheral nervous system. In the peripheral nervous system, this is a function of the Schwann cells, and in the central nervous system, it is done by the oligodendrocyte. So as the name indicates, in demyelinating disorders, the neurological dysfunction is characterized by either destruction or deformed myelin of the white matters. This is the normal appearance of white matter. This is the normal appearance of the white matter on the CT as well as on the MRI. In demyelination, there is destruction of the fat and it is replaced by the water. And due to high water content of the white matter, it appears hypodense on CT as well as on the T1 MRI, while on T2 MRI it appears hyperdense. This is the demyelination of the spinal cord. You can appreciate a hyperintense signal either involving the short segment or in the form of extensive meningitis. This is the bilateral demyelination of the optic nerve. This is seen in case of optic neuritis. Now we classify. Demyelinating disorder is a big group. It may be congenital or acquired. It may involve the central or the peripheral nervous system. We mainly focus on acquired demyelinating disorders. This may result from exposure to toxins, infections, or autoimmune disorders. Among autoimmune, the most important ones are acute demyelinating encephalomyelitis, MS, optic neuritis, transverse myelitis, and neuromyelitis optica spectrum disorder. This was previously called as Dravet disease. This is the relative prevalence of these disorders. The most common one are the MOG antibody associated disorders. MOG is myelin oligodendrocyte glycoprotein. This is exclusively expressed in the brain and it is present on the surface of the oligodendrocyte. Aquaporin-4 is also another antibody. It has very important role and it is expressed in the food process of astrocytes. So the classification of acquired demyelinating disorders is based upon the localization of the neurological deficit, whether it is monofocal or polyfocal, whether it is associated with encephalopathy or not, whether the disease is monophasic or polyphasic, and which type of antibodies are associated. So these parameters are used mainly to classify these disorders. Now we briefly overview these disorders. Optic neuritis is the inflammation and the swelling of the optic nerve, and about 30% of children with demyelinating disorder present as optic neuritis. It usually presents with unilateral or bilateral loss of vision, develop suddenly, and usually have a good outcome. Transverse myelitis, as the name indicates, is the acute inflammation of the spinal cord. It has number of etiologies. So for the diagnosis of idiopathic transverse myelitis, there is a specific consensus diagnostic criteria. That there should be bilateral and there should be the involvement of all the functions of the spinal cord, sensory, motor and autonomic. There should be a clear sensory level and the progression of the disease should be within hours or maximum up to 3 weeks. There should be the demonstration of spinal cord inflammation in the form of CSF gliocytosis or gadolinium enhancing lesion on MRI. And the important thing is that we should exclude other conditions that can present as myelitis. So what is the ADEM? It is the polyfocal demyelinating event and the characteristic feature is encephalopathy. But this encephalopathy should not be explained by fever. And on MRI, it is characterized by large, poorly demarcated lesions involving white matter and deep grey matter, and usually it is a monophasic disorder. These are the typical lesions of ADEM. You can appreciate multifocal, bilateral, large, poorly demarcated lesions, and it may present in the form of bilateral, symmetrical, hyperintense lesions. Usually ADEM is monophasic, but in 10 to 12% it may be multiphasic, that is characterized by relapses, and it may be the association with the optic neuritis, and sometimes the ADEM may be the manifestation of NMO spectrum disorder. What are the differential diagnoses? Now, as the ADEM, it has a characteristic feature of encephalopathy, so the most important differential is to exclude the ADEM from CNS infections like meningitis and encephalitis. And it is documented that in US about 30% of children diagnosed with encephalitis are ultimately proved as ADEM because of the widespread use of MRI. The other differentials are CNS vasculitis, stroke, autoimmune encephalitis, and it has to be differentiated from other demyelinating disorders. If there is no involvement of spinal cord, then it should be differentiated from GBS and cerebellar ataxia. And sometimes the ADEM must be differentiated from inherited causes of demyelination. The pediatric MS is a chronic demyelinating disorder, and the main feature is in MS there is no encephalopathy. So it is characterized by demyelinating episodes lasting for more than 24 hours and separated by more than 1 month. This is the revised 2017 McDonald criteria for MS, that if clinically we identify 2 or more lesions on MRI and there are 2 or more clinical attacks, then there is no need of additional information. However, if there are less than 2 clinical events or less than 2 lesions on MRI, then we have to demonstrate the dissemination of disease in space and time. What is the dissemination of disease in space? It is the involvement of the multiple areas of the CNS, and dissemination in time means appearance of more than one attack. On MRI, dissemination of space is the more MS involved, more common areas are the periventricular, juxtacortical, infratentorial, and spinal cord. On MRI, the dissemination in time means the presence of simultaneous gadolinium enhancing as well as non-enhancing areas. This is the typical areas that are involved in MS. And here you can appreciate juxtacortical lesions, infratentorial, periventricular, and spinal cord areas. These are the characteristic small ovoid lesions in the juxtacortical and in the periventricular areas seen in MS. In MS, corpus callosum involvement is very characteristic along with infratentorial, and the most important thing on neuroimaging is the presence of the black hole. These are the hypointense lesions noted on T1 weighted MRI. Like ADEM, MS should be differentiated from other demyelinating disorders, CNS infections, vasculitis, stroke, autoimmune encephalitis, basilar migraine, and metabolic disorders are also very important differentials of MS. NMO spectrum disorder is a chronic autoimmune disorder, and it is characterized by recurrent episodes of optic neuritis and transverse myelitis associated with positive factor 4 antibodies. This is the diagnostic criteria for NMO spectrum disorder, that there should be one or more core clinical event along with the positive aquaporin 4 antibodies. And the core clinical characteristics are optic neuritis, transverse myelitis, and the area postrema involvement. Area postrema is the area present in the dorsal medulla, and it is clinically characterized with intractable vomiting and hiccup. And symptomatic narcolepsy and diencephalon involvement is also very important clinical core criteria. And the optic neuritis of NMO spectrum disorder is characterized by long segment involvement, and usually it involves the optic chiasma. And the transverse myelitis is also the long segment extensive myelitis. This is very important question that whenever a child presents, this is the first episode, what is the probability that this child develop chronic demyelinating disorders? Although it is not clearly defined, there are certain factors that if initial episode is not associated with fever, prodromal illness, encephalopathy, and there is absence of MOG antibodies, and on MRI, there is either presence of black hole or bilateral periventricular lesions, then there is quite high chances that this child will go into chronic demyelinating disorders. In optic neuritis, the risk of MS is about 40%, and it is about 10% in transverse myelitis, and 15 to 30% of children with ADEM go into multiple sclerosis. Now, how these children should be approached? This is the usual approach that we mainly stress that it is the history that is important in neurology. But I can say that in demyelinating disorder, it is the investigations that mostly characterize the diagnosis. Because clinical features depend upon the site of involvement, it may result from the involvement. Any symptom can be the manifestation of demyelinating disorders. Now, first we have to rule out the infections and the systemic disorders. And regarding CSF, we have to document the proteins, pleocytosis, and simultaneous oligoclonal bands in the CSF as well as in the serum. And in the serum, MOG antibodies and aquaporin 4 antibodies. And the most important investigation is MRI brain. MRI should be done of brain, orbit, and spinal cord, with and without contrast. And the further investigation will be according to the site of involvement. So for the diagnosis of acquired demyelinating disorder, we should consider the multiple factors. History, investigations, especially MRI, we have to rule out the differentials and careful application of diagnostic criteria. Now, ADEM or MOG antibody associated disorders are usually seen in boys under 10 years associated with encephalopathy and prodromal symptoms. While MS and NMO spectrum disorder are mostly seen in children above 10 years. In MS, encephalopathy is not a characteristic feature. In NMO spectrum disorder, it usually presents with optic neuritis, and the optic nerve involvement is characterized by long segment and involvement of optic chiasma. This is the different involvement. Here you can appreciate NMO spectrum disorder, there is long segment involvement of the optic nerve along with optic chiasma. In MOG antibody associated disorder, there is bilateral involvement and the perineural involvement is characteristic. In MS, usually there is unilateral optic neuritis. This is the same MRI findings, involvement of both optic nerve and unilateral optic nerve. And in ADEM or MOG antibody associated disorder, there is bilateral involvement along with perineural inflammation. And these are the MRI findings, these are the characteristic areas. In NMO spectrum disorder, it is more characterized in the circumventricular or the periventricular areas, corticospinal tracts. These are the areas where there is high expression of the aquaporin 4 antibodies. In MOG antibody associated disorder, there is involvement of the deep gray area of the brain and the infratentorial. In MS, there is involvement of the corpus callosum, but it is the patchy involvement, periventricular, juxtacortical involvement is characteristic. This is the corpus callosum involvement of MS, and this is the NMO spectrum disorder. In MOG antibody associated disorder, usually there is no involvement of corpus callosum. This is the characteristic areas of NMO spectrum disorder, that is circumventricular, corticospinal tract involvement, and these are the multiple hyperintense lesions periventricular in MS. for involvement of triacetyl in NMO spectrum disorder and area posterior. This is the repetition that the large widespread involvement in atom and maybe the small regions in MS. The involvement of the spinal cord is also in NMO spectrum disorder. It is a longitudinal and sensing neuritis, mainly involved in cervical and thoracic area. While in MOG antibody associated disorder, there is involvement of the conus medullaris, and in MS, there is short segment involvement of the spinal cord. This is the extensive myelitis of NMO spectrum disorder and short segment involvement in MS. And usually in CSF, in MOG antibody associated disorder, we can appreciate serum MOG antibodies in MS oligonucleotide bands and NMO spectrum, usually alpha-4 antibodies. And NMO spectrum disorder is more severe among all these. So the treatment, and there is multiple systems involved, so the treatment is multidisciplinary and symptomatic, supportive, and complication is the treatment for all the conditions. In the specific case, we use IV corticosteroids, immunoglobulins, or plasmapheresis. Usually we use solomidrol 30 mg per kg per day, and we use for 5 days. If the disease is severe, we can use immunoglobulins as well as the plasmapheresis pharmaceuticals. So to summarize, acquired demyelinating disorders, although they are not very common, but very important because of their wide clinical presentation, they come in differential diagnosis of number of neurological disorders and often create a diagnostic dilemma. So, considering these in differential diagnosis is very important because early diagnosis can prevent morbidity as well as mortality. So, this was all about